uveitis. Before I go further, I would like to introduce today's guest speaker. Of course, he needs no introduction to the audience, but I just wanted to highlight few of his achievements, rather his contribution to Indian and world ophthalmology. So who are aware of his tenure in PGI would know that he was instrumental in transforming one room eye clinic to a advanced eye care center at PGI, which is one of the state-of-art eye care facility. And I have not seen a better eye care center in my short career as an ophthalmologist. And undoubtedly, it is one of the best centers in India. Further, he was the first president of USI, and he took an onus on himself to teach the art and science of uveitis to many. And this is being reflected by numerous illustrious teachers that we have now in uveitis, including JB sir, Anita ma'am, Vishali ma'am, and Reema Bansal ma'am, and the list goes on and on. And he has been inspiring many of us to take up uveitis as a specialty, which we usually would have not taken up before we have met him. His other contribution to ophthalmology is the number of publications that he has made. And I still remember last time when sir had visited Chitrakoot, he told us that if a tree fells in a jungle, does it make a sound? So that was the question that he had put. And so his emphasis has always been on the quality of publications rather than quantity. And you can see from the citations that he has got over the years. So you can have a lot of publications, but if it's not cited or seen or read, then it carries no value. And these are the pictures which I've taken from one of his publications in Survey in 2007. And it has got more than a whopping 650 citations. That's from one publication itself. So to conclude, if Sachin Tendulkar, we all know him as the cricketing god in India. If there has to be a god of ophthalmology, it has to be none other than Professor Amod Gupta. Sir, thank you so much for kindly accepting our invitation, and we'll not take any more time, and we'll start with the first presentation. Can we have the first presentation?
Yes, sir.
Gaurav?
Good evening, one and all. So today I would like to present a case of relentless progression of serpiginous-like choroiditis in a young patient. A 17-year-old female patient came to us with chief complaints of left eye diminution of vision for the past 3 months. On presentation, her right eye revealed a visual acuity of perception of light. In anterior segment, there was evidence of festoon pupil, pigments on anterior lens capsule, and a posterior subcapsular cataract. Otherwise, the AC was quiet. Posterior segment revealed widespread healed choroiditis. Now coming to the affected eye, vision was finger counting at 1 meters. AC showed a cellular reaction of 1+. There were cells in the anterior vitreous phase, and the intraocular pressure was 14 millimeters of mercury. Now coming to the fundus picture, there was evidence of widespread active serpiginous-like choroiditis, including macula and in the inferior periphery, and we can clearly make out that the edges are active. Along with that, there were few granulomatous lesions away from the main lesion. So a working diagnosis of right eye healed choroiditis and left eye active serpiginous-like choroiditis was made, and the patient was evaluated on that lines. In investigations, MAN2 came out to be strongly positive with 16 millimeters of induration. HRCT thorax was within normal limits. The HIV, VDRL, TPHA were negative. Complete blood picture was within normal limits. ESR was 28, and at baseline, her renal and liver function tests were within normal limits. A fundus fluorescein angiogram was performed, and in progressive frames, it showed progressive leakage, indicating activity. Also, in initial phases, we can see that in areas of granulomatous lesions, there is evidence of RAP lesion. So the patient was admitted for intravenous dexamethasone for 5 days, along with antitubercular therapy. Following antitubercular therapy and intravenous dexamethasone, the vision had improved to 2/60, and in comparative photos, we can see that the scarring has set in and the lesions were resolving. So the patient was discharged on antitubercular therapy, oral steroids 50 milligrams, and azathioprine 50 milligram OD was added. The patient was doing well. However, 2 weeks later, she presented with severe pain, headache, and periorbital swelling. The vision had dropped to finger counting at 1 meter, and on fundus picture, we can see that the edges have again become active and there was evidence of new lesions. Also, her liver function test had drastically gone bad. So the SGOT was almost 4 times the normal values, and this made us to stop isoniazid, and we had started her on moxifloxacin and streptomycin. Also, since the liver function tests were deranged, the azoran was stopped and visolon was stepped up. In this visit, we also performed a B scan, and it showed evidence of fluid in the subtenon space, indicating scleral inflammation. So this is the clinical picture of the patient, and it mimicked orbital cellulitis. So in the next 1 week, the patient was also given a course of intravenous antibiotics. However, her condition worsened further. So there was relentless progression of the uveitis. Cellular reaction had increased to 3+ cells, and there was evidence of a subretinal abscess. In this comparative photos, we can see that in previous images, there was evidence of scarring. However, here we can make out that even in the previously scarred areas, the activity has increased. There were new onset hemorrhages and exudative detachment in the periphery. The liver function tests were somewhat normalized, and the patient was again given a course of intravenous dexamethasone for 5 days. Following intravenous dexamethasone, her vision had stabilized at perception of light, and the patient was discharged on oral steroids and the modified antitubercular therapy. So in June, when the patient came, her vision had further decreased to denying PL, and however, the fundus photo showed that the lesions were healing. So in view of denying PL vision, we had further tapered the steroids, and the antitubercular therapy was continued. In the following visits, we can see that there was further healing of the lesions. So the steroids were further tapered and the patient was shifted to continuation phase. By November 2021, this was the fundus picture which had resemblance to her right eye, and it was there was evidence of burnt out choroiditis. Thank you.
Over to you, sir, for your comments. Sir, you are muted, sir.
I think.
Yes, sir, you are audible now.
No,
you are audible. Yeah.
So what Gaurav has presented is one of the most challenging patients in my own experience. Having seen maybe close to 1,000 patients of similar kind, this patient is the most challenging, the most unfortunate, the kind of outcome this patient ever had. Could we have changed the outcome? I mean, she's just a 17-year-old girl. Okay. Could we have changed the outcome of this patient? It's $1 million question. You already told us that the right eye showed up a picture which was kind of a burnt out, uncared for. She probably never received any treatment in the right eye during her course of her illness. And, first time when it gets involved in TB choroiditis, it goes unnoticed. And I would have seen a number of such patients where the vision, not exactly light perception or no light perception, but extremely poor vision we have seen. Now, in the left eye, what you have is a very classic, I would say, multifocal serpeginoid choroiditis. And the presenting vision is poor. I think she has been, it couldn't have developed in a day. These lesions, they don't, she would have taken several weeks or months to reach a stage where her vision is down to, you said, counting finger 1 foot. Is that right? And why did she ignore the symptoms, visual symptoms, for that long? The second, I mean, you rightly investigated what with HRCT, and I'm a little bit surprised that she did not show a lymphnopathy on HRCT, because I think many of these patients do have extrapulmonary tuberculosis, most of these being tubercular lymphnopathy. And we have ourselves looked at some of the patients, and at least in 1/4 of those patients, we could take a sample from the lymph node, and which would show TB granuloma, and half of those actually we could also demonstrate the presence of acid phosphobacilli in the binaural aspiration cytology. Now, so why your patient is not showing any evidence? Is it because lack of, we did not go over her systemic review thoroughly? That might have helped. Now, anyway, you did start the patient on anti-TB drugs and IV methylprednisolone. I would not have started this girl on IV methylprednisolone. It shows a kind of a panic reaction. If you read our first paper, which we published in 2003, I believe, that came out of a large number of patients of what we at that time called serpiginous choroiditis or serpiginous choroidopathy. And many of these patients were not responding to conventional corticosteroids. And we put them on, even on IV methylprednisolone. We gave them even cyclophosphamide. And when we gave these IV cyclophosphamide and IV methylprednisolone, these patients became frankly tubercular. There was no evidence before that. So in that series of 7 or 8 patients where we have shown by several means the presence of tuberculosis, one of them was, we thought, the use of intravenous corticosteroids or cyclophosphamide. We didn't know what was happening, and everybody said use more and more immunosuppression, use triple immunosuppression. They were saying all that in literature, and in our experience, we were ending up with some of them converting into frank tuberculosis. So I would have held my hand, giving intravenous methylprednisolone, because that would take away all the immune response from the body. So you are left helpless in the presence of a warlike situation in the eye. Sure enough, we know, and the current experience is probably 50% of these patients show paradoxical worsening. Okay. And this is somewhat similar to Jarisch-Herxheimer reaction that we see with syphilis when we treat. And that is because of the release of antigen and sudden release of antigen when you give them anti-TB drugs. And you don't know where these bugs are hiding all over the body. They are, probably dying, not only in the eye, but elsewhere. So you have a very serious cytokine kind of a storm. And I think there's a paper from Dr. Vishali Gupta from the PGI, where they have shown that at about 2 weeks after starting anti-TB drugs, the patient showed in their blood samples elevated TNF alpha. So beside other cytokines, so TNF alpha, as you know, is the main inflammatory cytokine which plays havoc with the eye. So that was something which I had been actually proposing to do that study, that there is something, which suddenly there's a kind of a stormy nature it takes. So that is seen in about half the cases, and that can be very, very discouraging for the patient to continue with the treatment, to continue with the anti-TB drugs, or continue with the corticosteroids. So because one of the patients I don't forget, because I put him on anti-TB drugs and he was already on corticosteroids and for retinal vasculitis, and young man coming from somewhere in UP, again about the same age, 18, 19 years old. And he thought when I wrote him anti-TB drugs, he stopped corticosteroids all of a sudden. He thought that since I've written a different prescription and I didn't emphasize, or probably I failed to impress upon him to need to continue corticosteroids. So he came back with the massive serpiginous-like choroiditis, which took him to almost like blindness. And no matter how much steroids I gave, ultimately he had a very bad outcome because he developed avascular necrosis of the hip, the back of the femur, and he required bilateral hip replacement. So that was such a sad outcome of miscommunication. So I think you need to communicate with the patient and the parents of the patient. The need for consistency. There is compliance has to be when you start patient on corticosteroids. Compliance has to be very good. I wouldn't have started the patient as a therapy. There was no need right in the beginning. And even if we felt the need for an immunosuppressive, I would have thought of injecting intravitreal methotrexate, 400 micrograms. And there are several reports now which suggest that we can give methotrexate safely. And I myself have given, and there has been a good response. The other option is giving intravitreal dexamethasone implant, the Ozurdex. I think there's a paper from Vishali's group, where they have given in patients who are showing paradoxical reaction. Now, the third option in this patient would have been, which I would have personally preferred. You guys being surgeons, there should be no hesitation to go in and do microincisional vitreous surgery, remove the vitreous gel. And in our own experience, which we reported with Dr. Rima Vansal several years ago, almost like 110 eyes, where we had done microincisional vitreous surgery, 23, 25, or 27 gauge. We don't call it sutureless. You have to be aware of that because many of these patients will require putting a stitch or two. So our experience was exceptionally good. And the fear that we all carry that surgery in uveitic eyes, active uveitis inflammation is bad and lead to worse outcomes and people go blind. That's, I think, related to cataract surgery. That's not related to vitreous surgery. I can tell you that in our experience, we did vitreous surgery in all those patients, removed the vitreous gel entirely. And we found, to our surprise, that some of these patients, like the one you have, started responding even before we changed the. And the reason, I presume, and I believe, is because all the inflammatory cytokines get trapped in a bursa in front of the macula, in front of the retina, and they kind of get locked up. So once you remove the vitreous gel, they are easily flow out of the eye. They don't stay. They don't reach a threshold value which will be required for perpetuation of inflammation. So, the two things are happening in inflammation. One is the initiating events, which initiate, and then there are events which perpetuate or keep that inflammation going. Okay, so these cytokines which get trapped right in front of the retina are the ones which are kind of, not letting the fire in the eye to cool down. Okay, so once you allow them to exit away from the eye, quicker exit, they don't reach that threshold value, and that's how the inflammation tones down, comes down, and patient starts responding. That is one major experience, and not my own experience. If it were my own experience, people could question that. So the same thing has been reported in a large series by Dr. Soumya Basu while he was in Bhubaneswar, where he has recommended strongly doing surgery because based on similar kind of experience. So two disparate centers, two different groups reporting somewhat similar, it strengthens the idea that in these cases, we could, and in fact, in our set of patients, we could cut down on the dose of corticosteroids. We did come across 1 or 2% complication in the earlier in the series when we got carried away by sutureless. The inflammatory eyes, the inflamed eyes don't tolerate hypotony. So these sclera doesn't have it loses its inherent capability to spontaneously shut down those fibers. They don't come back together. So you should not leave any leaky port. So you could put a stitch there and make sure that the eye is inflated, is not hypotonic, because it will lead to choroidals, and you would again have sleepless nights. So you take care of that part. Otherwise, the eyes take care of itself. Now, what is surprising here? The second aspect, before I come to that, is the presence of multi-drug resistant MTB bugs in the eye. And we have now several publications with the courtesy Kusum Sharma, and I think in our experience, 5 to 7% of patients with serpiginous like choroiditis may harbor TB bugs in their body which are resistant to drugs. So these days, we don't have to really go for culture because you'll never be able to get a positive culture from the ocular tubes. But if you do a molecular testing, either by using Gene Expert Ultra or something which has come new now, or do a line probe assay, or you do gene sequencing from the amplicon that you get from a PCR product, you could, and we did find that 5 to 7% of our samples, and when we treated them on MDR treatment, specific therapy, they responded very well. So third thing which you could have done, especially when the patient lesions came back with a vengeance after 2 weeks of showing initial response. So I think that could be either because of the MDR, or more likely it was compliance issue with the patient. Young patients notorious for being non-compliant. You miss a dose and all that. But obviously led to the formation of an abscess, a scleral involvement in abscess which went into the orbit, caused. I have never seen lid edema, periorbital edema, the kind of what you have shown in your patient. And I think I would encourage you to publish this paper as a unique poor outcome in a patient who was a straightforward case of serpiginous like choroiditis, for people to maybe send it as a clinical challenge in the retina, or some such, as a challenging patient, because it certainly is a challenging patient. So what else we could have done? So if you are familiar with Dr. Manisha paper on the use of intravitreal moxiflox, which she gave for 1 milligram every week, and coupled with anti-VEGF therapy, Lucentis, Eylea, or Avastin. And there's a rationale for doing that. And rationale is that these granulomas, and even in serpiginous like choroiditis, there are choroidal granulomas at the end of the story. So that is a hypoxic granuloma, and it expresses a lot of VEGF. In her series of patients, I think she found almost 10 times higher levels than what you see in so much talked about age-related macular degeneration. Such a massive rise in VEGF levels in these patients. And once you give anti-VEGF, Lucentis or Avastin into the eye, she has shown beautiful resolution within a matter of days. In fact, they did not require more than 4 injections. And now we have, specifically for choroidal granulomas, there are a number of publications, I think more than 15 cases reported. And this is currently, I don't know whether you're familiar with host-directed therapy. And this is actually the host-directed therapy, where you're strengthening the host response to the presence of Mycobacterium tuberculosis to control it more effectively. It allows the uniform distribution of the anti-TB drugs into the otherwise with so much VEGF, so much capillary dilatation and leakage, the drugs don't reach out to the center of the granuloma where it needs to reach. So uneven distribution. The drug resistance develops because of that. And ultimately, eventually it happens that in that kind of scenario, it's like a monotherapy. It's not even a multi-drug therapy. So once you give anti-VEGF, so it makes a lot of sense to use anti-VEGF. So these are my straight thoughts on your patient. I think I've stretched more time on this patient, but I thought that this was, we had to cover all the aspects of this.
Yes, sir. Absolutely, sir. There's no, as such, your time is more important than us. So
No,
we
I'm
will
a free man.
be happy to listen to you, sir, as long you can.
I'm a free man and I express my views.
We also, on the hindsight, we also thought, because there were granulomas to start with, also we could also identify RAP lesion on FFA.
Yeah.
So we could have injected anti-VEGFs, and that point of not to start these patients on IV dexamethasone and immunosuppress them to that extent is well taken, sir. And that should be what we should be doing for these ocular tuberculosis patients. Thank you so much, sir. We can move to the next case, which is again on tuberculosis. And Dr. Pranav would be presenting.
Good evening.
Pranav, your slide is not coming.
Yes.
Yes. Okay. Please start.
Yes. Good evening. So I'll be presenting a case on a ciliary body mass. So the case was a 17-year-old male who presented with a left eye redness and mild pain for 15 days. And there was neck swelling associated for since the last 20 days. There was no history of TB or TB contact. And there was no history of fever, breathlessness, joint pain, skin lesions, or GI disturbances. So on the anterior segment examination, we saw inferior sectoral scleral congestion. And on 90-day examination, we saw a dome-shaped lesion, which was seen at the site of the ciliary body.
On systemic examination, there was presence of neck swelling. And on the fundus picture, the disc and macula were normal, but there was inferior focal vasculitis. And on the B scan, we saw a dome-shaped mass, which was present on the transverse and anterior and inferior quadrant. And on ultrasound biomicroscopy, there was a dome-shaped ciliary body mass, which was at the inferior quadrant, and it was homogeneous. So we made a diagnosis of differential diagnosis of ciliary body granuloma, ciliary body melanoma, ciliary body epithelioma, and ciliary body secondaries from thyroid or parathyroid gland. And we went ahead with investigations. On the investigations, we found that the ESR was raised while the Mantoux test was negative, and the TSH and thyroglobulin and CRP were also raised. So we asked the patient to go to a physician, and he advised ultrasound thyroid, in which it was seen that there was an adenomatous goiter with cystic swelling, while on the fine needle aspiration cytology, there was a gross specimen pus-like fluid, and acid-fast bacilli was seen, suggestive of a tubercular abscess. On the cytology, there were polymorphs, lymphocytes, and macrophages with a caseated necrotic background. And on HRCT chest, there were diffuse tiny miliary nodules in all lobes of both the lungs. So we made a diagnosis of left-eye tubercular ciliary body granuloma with miliary tuberculosis, and we started the patient on anti-tubercular drugs after approval from the physician. So after 15 days of presentation, the patient came to us on follow-up, and the inferior sectoral congestion was still present. On 90-day examination, on the primary visit, there was only one lesion, while on the second visit, there were multiple ciliary body granulomas inferiorly. As we can see at presentation, there was no disc edema, but after 15 days of follow-up, when the patient was on ATT, there was disc edema. And inferiorly, there were two ciliary body masses which were shadowing in the inferior part of the retina with inferior focal vasculitis. So even on the OCT, there was optic disc edema. On the B scan also, the size of the lesion increased, and on ultrasound biomicroscopy also we could see that the size had increased after initiation of ATT. So we thought of it as a paradoxical worsening after initiation of ATT, and we started the patient on oral steroids along with ATT. So on at 45 days of follow-up, we can see at presentation there was inferior sectoral congestion which had reduced. The swelling had also decreased on the neck significantly, and on consecutive visits after 15 days of presentation, we could see when the patient was on steroids and ATT, the disc edema had reduced, and even the ciliary body mass size had decreased significantly. On consecutive B scan and ultrasound biomicroscopy, we can see after 15 days of follow-up, when the patient was started on steroids, the size of the lesion had reduced, and even on ultrasound biomicroscopy, the size had reduced. Thank you.
Hello. Sir, you are muted, sir.
Unmute.
Yes, sir.
Now it's okay, is it?
Yes, sir. Yes.
Now, again, a great case, Alok, great presentation. I think very well documented, I must say that. It's not every day that we see the TB granulomas in the ciliary body. I mean, you see a lot of these most of them are located in the posterior pole, the choroidal granulomas due to tuberculosis or sarcoidosis. Where here you have a unique young man who's asymptomatic. I mean, that is what is surprising to me. You probably then need to revise the criteria in Indian patients who claim to be symptom-free, because a person who ultimately ended up having a disseminated tuberculosis, for which there was every indicator present. So somebody is saying that I'm not audible. Am I audible?
Yes, sir. You are audible, sir.
Yes.
So now, for instance, Monto's reaction. A negative Monto's is anticipated in patients, and if you are suspecting TB etiology and Monto's come negative, all the more reason that you need to look for disseminated tuberculosis, because in a disseminated TB, you will have Monto's reaction negative. Okay. Now, the surprising thing is the thyroid TB. You know, thyroid tubercular granulomas are reported, abscesses are reported, but these are exceptional. These are extremely rare. I don't think there are more than 100, 200 patients reported ever in the literature, and they feel that even in the disseminated tuberculosis, thyroid gland per se is not a favored site because of the thyroid hormone or the kind of vascular supply it has, or kind of colloidal material, or the excess iodine, which doesn't allow TB to set up infection in the thyroid. But then the availability of thyroid gland for fine needle aspiration biopsy is a great site to take a sample, which was done and which eventually led to the diagnosis, and you could demonstrate that. And if that were not available, there might have been, anterior cervical glands possibly involved, and one could have taken a fine needle aspiration biopsy. We have done from the axillary lymph nodes, we have done from the anterior cervical lymph nodes, and they have shown AFP positive. So rather than going to the lung to take EBUS or any such biopsy, if it is available outside the body, easily approachable, I think one would prefer that. Now, the point is, when the patient presented to you, you didn't know whether it's medullary epithelioma or was it a melanoma, or was it an abscess. So first tool that you do is use an ultrasound or a UBM in this case, and UBM would have certain characteristics. Okay, and typical hypoechoic, which is shown in your UBM, it's a very nice demonstration of a TB hypoechoic cavity, in your patient. So that's why it's worth reporting this kind of a patient. On the other hand, secondaries would be hypercellular. There would be, or malignant melanoma would be medium to low to medium reflectivity and echogenicity. So it will not show a hollow. The epithelioma, medullary epithelioma arising from non-pigmented epithelium, ciliary epithelium, would be hollow cavities, absolutely, not hypoechoic, but hollow cavities. And there could be single or multiple. Okay. And primary, now the most challenging lab test which came positive in your patient was thyroglobulin levels. Now, thyroglobulin levels in a 17-year-old is a young boy, okay, because thyroglobulin levels are associated with cancerous growth, okay. And whatever is my information, TB granulomas don't have that kind of thyroglobulin levels as your patient has, okay. So that is a very unusual, and one has to look up. I don't know the answer to that, but that could have led to a search. For instance, if your fine needle aspiration didn't reveal AFB, then you would be forced for an answer, and you would be looking for, is that ciliary body metastasis from the thyroid cancer. Now, thyroid cancer, when it metastasizes, it doesn't metastasize that well to the eye. It metastasizes to other places, maybe the lung and liver, and primary metastasis to the ciliary body of the forehead would be unusual from a thyroid gland. Okay, so I think in the long run, what you have shown is again a paradoxical reaction, which makes it an unusual case, because paradoxical reaction we have failed to demonstrate in other phenotypes of ocular tuberculosis. We have shown it very well in serpiginous-like choroiditis, which is the best well known. We have not shown in retinal vasculitis or in granulomas, but people have shown in TB lymphadenopathy, mediastinal and other lymphadenopathy. People have used CT scans and to show the size increasing after starting anti-TB drugs, which you are showing on UBM and other imaging modalities. You're showing the number increased, the size increased. So I think that's a very interesting to document that these choroidal granomas, and in future people would be looking out, because they have not been looking out for paradoxical reaction in these patients with choroidal granulomas, or in this case ciliary body granuloma due to tuberculosis. But otherwise, I think I find it an outstanding case. So
Thank you,
Manisha
sir.
has seen, she writes that she has seen paradoxical reaction in granuloma cases. So it's great because, granulomas are not very common and they always indicate the presence of disseminated disease. And if Manisha has documented, I think it's very nice. It strengthens our case for, paradoxical reaction in the ocular tuberculosis.
Can we unmute Manisha ma'am as well? She is there. The host. Anyway, we move on to the next place, sir.
Yeah.
Good evening, Alok, and good evening, sir.
Yeah.
Good evening,
It's nice to see you.
Nice to have you, ma'am. Thank you so much for joining in.
Same here, and very interesting cases, and it's always a pleasure to listen to, sir.
Yes. Thank you.
Yeah, I think it's a great opportunity to learn. I don't get to see patients, but I get to see patients in an oblique manner, through you guys.
Sir, I was just wanting to ask one thing, that the UBM finding with that hypoechoic center,
It's
could that,
that's it, because of the caseation.
that's a very unusual thing, sir. I've never seen a ciliary body granuloma.
It's a rare, it's exceptional, but not that it's not known. It's well known. Ciliary body tubercular granuloma is well known. But compared to the choroidal granuloma, perhaps we are not even looking for it. Here the Q was the localized scleral redness inferiorly, which is a favorite site actually, by the way, for ciliary body granuloma, is the inferior site, inferior anterior, what you have shown. But if that were not there, we would not even be looking out for ciliary body granuloma. And unless you do UBM, which we don't do, conventionally in choroidal granulomas, so we are not even looking for it.
So we had just two signs of inflammation in that case. One was the scleral inflammation, and the other was vasculitis.
Vasculitis, yes.
That favored inflammatory pathology.
disease.
That's why we kept granuloma as first diagnosis. Thank you so much, sir, for the comments, and we'll move on to the next case. If Tanvi is ready, please share your screen. So next case is a case of infective scleritis. Tanvi.
Good evening to all. I am presenting a case of a 54-year-old male who came to us with a complaint of sudden onset of pain, redness, watering since 15 days. He also gave the history of injury by wooden stick and was advised topical antibiotics after consultation to a private local place. He had best corrected visual acuity of 6/6 and 6/9 in right and left eye respectively. So on examination, we can see a diffuse 360-degree deep scleral congestion, and there is a pus point, which is a heaped up lesion. So looking at the clinical examination and on fundus, there were evidences of shallow choroidals. We ruled out the evidence of any retained foreign body. On B scan, the patient showed fluid in the subtenon space, although the vitreous cavity was clear. So considering the history and clinical examination, we made the diagnosis of scleritis secondary to infectious cause. We planned the patient for left eye scleral debridement, and we also did the uveitis profile, which contained CBC, TPHA, HIV, HbICG, and VDRL. So in debridement, we debrided whole of this area, uh, which had all necrotic tissue, and we debrided the sclera till the time we had seen the uveal show, and the debrided area was left open. So on the post-op debridement 1 day, the smear didn't show any organism. Uveitis profile was within normal limit. So we started the patient empirically on moxifloxacin eye drop one hourly, betadine eye drop for a larger cover 6 times a day, and tablet Indocap SR 75 milligram BD. So these are the photograph of post-op day 1, 2, and 3. Although there was not much healing, but yeah, granulation tissues at the edges were very well seen. So we decided to discharge the patient on the same treatment, and we added the patient with ciprofloxacin 750 milligram BD. So the patient came for follow-up after 7 days. There was no sign of worsening, but yeah, again the edges showed the granulation tissue. While there was no yield in the debridement sample. So we continued with the same treatment and asked the patient to review after 7 days. So now this is the photograph of debridement 15 post debridement 15 days. We can see a new lesion, new pus point, which are consecutive with the previous lesion. So looking at this nature of the pus point, we were little inclined towards the fungal etiology post trauma. So we planned the patient for redebridement and decided to give the patient with empirical subconjunctival amphotericin. So these are the photograph of the area which we debrided in the second sitting. We debrided whole of the 360-degree conjunctival in a advanced circumferential fashion, and we debrided till we could see uveal show. So as we can see here, these are the photograph of day 1 debridement. 360-degree uveal show is there, scleral thinning is there. We started the patient with oral ketoconazole 200 milligram BD, moxifloxacin 1 hourly, and betadine eye drop 6 times was continued. We asked the patient to review after 1 week post debridement 2. We can very well see the healing of the infectious part of the scleritis. Although there was inflammation, this could be maybe due to topical drug toxicity. So as there was no evidence of infective part, so we decided the patient to start on low dose of topical steroid, and ketoconazole oral tablet was continued. So here are the photographs of day 1 post debridement 2 and 4 week post debridement. There is a complete resolution of scleritis and inflammation, although there is a sequelae and uveal show as a part of scleral thinning. So my case is open for discussion. Thank you for your patient listening.
Thank you, Tanvi. Sir, can we have your comments, sir? Sir, you need to unmute yourself, sir. You are still muted, sir.
Now I'm.
Now you are unmuted.
There's a little delay by the host who is not letting people to unmute. So anyway, it's a great case, Tanvi, that you presented. Very happy outcome, I must say that, and congratulate you on that, because it requires a lot of strength of character to go ahead and debride sclera, and you have shown excellent outcome of that. So sometimes we have to be very aggressive in approaching a case where we strongly suspect infective etiology. And particularly, compared to the Western world, I think our share of infective etiology in scleritis cases is at least twice what is seen in the rest of the world, if not more. And, trauma is a great, because normally you would see infectious scleritis following, say, surgery. Whatever cases I have seen, have been following, say, extracapsular surgery or following, tritium surgery, especially in those days when we used to apply mitomycin C. I'm not sure whether they do that these days, but long time back, almost like, 40, 50 years ago, mitomycin C after excision of the tritium was a very standard therapy. Okay. And that was the culprit for some of these infections to set in and necrosis to set in. So, that apart, what I have seen is the trauma, wooden trauma, or with, when they're going into the fields or they're going into the forest for, sometimes collecting grass or some such thing, they get hurt with the any of these, thorn injuries or some such stuff. So that it will let the infectious organism, the fungus particularly, with organic matter, it will be common, it will be suspected. Although in your case, I think you failed to demonstrate the presence of fungus, I would strongly feel that this patient had infectious scleritis due to aspergillus or one such fungus. And, it was a necrotizing. So sometimes when you see the patient the first time, one, you have to see either in daylight or you see in red-free light, of the slit lamp to look for the deeper congestion of the sclera, to look for swelling of the sclera. You can do anterior segmental CT if you have these days to exactly know the extent, how deep is the presence. And if you had done that, or possibly a UVM, you might have seen the extension of the fungal scleritis into the eye, because that is what we fear the most. I think long time back, I think more than 40 years ago or around that time, or 35 years ago, we reported a couple of cases of fungal scleritis where the treating ophthalmologist had given a subtenon Kenacort. I mean, hang on, you give subtenon steroids without establishing the diagnosis of scleritis, and of course, there have been papers, people have reported from the Western world use of dexamethasone or subtenon Kenacort for some of these cases, but fortunately, we are smarter here, thinking our patients may be infectious and not non-infectious, because that will hasten the entry of the fungus into the eye. And, the spread of the non-infectious scleritis doesn't go around the eye. The case like your case went around. Okay. So one looks very meticulously for the fungus because it's difficult to locate. You will not find in the necrotic debris that you remove while you are doing debridement. I think you would be seeing if you went ahead and at the edges of the spreading scleritis, if you're taken a biopsy or some such thing, and because it will be found within the scleral lamellae, not find in the debris. So that is how you look for the fungus. And but injury with a wooden stick, I have seen an orbital fungal infection caused by a wooden stick. Actually, the entry wound was so tiny, it was not even visible. And when we did the surgery, we could remove a very long foreign body which had gone right in, and which we discovered on some of the orbital imaging. So one would look for even the orbit. So while you were looking for into the eye, one would look also into the orbit. Sometimes it could be, come as a surprise. You have managed it very well, I would say that. And I think reported a few cases. I don't know, those cases were seen at your institute or were seen in Bhopal, where she did the debridement for great. I think he has shown excellent outcome like your patient. And choice of antifungal, I think you are being very conservative when you use ketoconazole. I don't know whether it was the availability issues, because one would use either itraconazole or voriconazole to be more effective, and for a long period. I think no antifungal therapy should be given less than 3 months, because it's extremely difficult to eradicate, and this avascular structure, the drugs don't reach, and they lie there. And we have seen in those cases of, I think Dr. Dogra reported on our behalf some of those cases of recurrent fungal endophthalmitis, where they respond very well initially, but if you do not follow it through, with a long-term therapy, they tend to recur, because it's very difficult to eradicate fungus from their ocular tissues, anywhere they might be. Okay, so I would argue to treat it longer than what you've done, about 3 months, I would say.
Thank you, sir. Thank you for highlighting how do you differentiate infectious from non-infectious, which at times can be very difficult for someone who is seeing scleritis not very often. So
yes.
And we do get, sir, in this part, because these patients, they are from farmers mostly. They go to jungles, they get these injuries while they are moving around in the cycle and all. And though they don't
in the eye. It's absolutely asymptomatic patient. And these guys are very sturdy, they are working the fields. Small little injuries, they don't even mind. It's like that. But you as ophthalmologists have to chase that angle. So bacterial infection, scleritis following surgical procedures, and post-trauma is mostly the fungal scleritis. I mean, to summarize this patient. Great patient.
Thank you, sir. And we move on to the last case for today. And Dr. Anu will be presenting the case. Anu, please start your presentation.
A very good evening to one and all. Co-infection in uveitis is a diagnostic challenge. A 30-year-old male presented to us with chief complaint of diminution of vision in left eye for 1 week and right eye for 7 years. He gave history of redness in right eye in 2007, treated with topical and oral medication. He also gave history of recurrent painless mild redness in both eyes since 2015, which used to get relieved on topical treatment. There was also history of unilateral inguinal lymph nodes since 1 year, which were gradually increasing in size. The best corrected visual acuity in right eye was 1/60, and in left eye it was 612 parts. On examination, right eye showed old pigmented keratic precipitates with posterior synechiae extending from 3 to 6 clock hours, and there was complicated cataract of nuclear sclerosis grade 3, subcapsular and cortical cataract. Left eye had fine keratic precipitates and anterior chamber cells of grade 1. And there was subcapsular cataract with cortical cataract, and pressures were normal in both the eyes. Posterior segment was visible only in left eye, which showed grade 2 vitritis with 2 yellowish retinitis lesion along the supratemporal and intranasal vascular arcades. There was presence of chorioretinal scarring throughout the periphery along the vessels, and there were also perivascular scarring along the arcade. What we saw was macular edema with ERM, which was also evident on OCT. The OCT scan passing through the retinitis lesion showed hyperreflective homogeneous thickening of all the retinal layers. On fundus angiography, the right eye showed a hypogenous early hypofluorescent lesion corresponding to the lesion which later on developed dot hyperfluorescence, which kept on increasing in intensity and area, which had with overlying vessels staining and leaking. The disc was hot and there was perifoveal leak, and there was leakages around the chorioretinal scars in the periphery. The baseline investigation showed normal hemoglobin, blood pressure, and random blood sugar, and the hemogram was normal with normal renal and liver function tests. The MON2 test was 17, which was strongly positive. The HRCT was normal with non-reactive HIV. The VDRL was reactive with the titers being more than 1:8. The TPHA was positive. CSF VDRL titer though was negative with normal CSF analysis. So on the basis of clinical presentation and positive serology, we treated patient with intravenous ceftriaxone 1 gram BD for 14 days. And we started topical steroid and cycloplegics in left eye, which led to complete resolution of retinitis lesion and also the inguinal lymph node resolved. But the edema persisted and the patient was discharged on topical treatment. At 2-week follow-up, patient came with same clinical picture but slight increase in macular edema. At this visit, patient was advised for intravitreal tamsunolone or Ozurdex, for which he was unwilling. So we started the patient on diflupred 4 times and kept on close follow-up, weekly follow-up, until he developed a new lesion after a month inferior to the disc and slight drop in visual acuity. The OCT scan passing through the new lesion showed RP elevation with the focal separation over it of RP and Brooks membrane, and the gap between showed moderate hyperreflectivity. There was a pocket of SRF nearby, and the macular edema increased in size. On the same treatment, after a month, patient further deteriorated with progression of the lesion, development of disc edema, and a newer lesion infratemporal to the disc. And there was increase in SRF and macular edema. At this visit, we repeated the fundus fluorescent angiogram of the left eye, which showed early hyperfluorescence to the corresponding lesion, which later on developed leakages around the edges of the lesion. And the disc was hot, there was perifoveal edema, and the chorioretinal scars in the periphery, there was leakage. So on the basis of strongly positive MON2 and multimodal imaging, we started patient on antitubercle therapy and weight appropriate oral steroid. Though the patient was taking low dose steroid, and we repeated VDRL, which was still reactive, and the repeat HIV was non-reactive. And patient after at 2-week follow-up presented to us with slight improvement of vision, and the chorioretinitis was resolving, and the RP elevation completely resolved, and the macular edema, disc edema, and SRF decreased. And at 1 month follow-up on the weight appropriate oral steroid, there was further resolution of the chorioretinitis, and the SRF and macular edema decreased. Hence, we tapered down the steroid and we continued the antitubercle therapy. Thank you.
So your comments, please, on the case. I think we had shared this case with you, and you had previously. So you are unmuted. You have to.
Interesting. And for the simple reason that the patient has had, he's 30 years old, and he's had right eye affected 7 years ago, isn't it? And he shows evidence of synecdoche and pigment, and even in the left eye, I think she has shown those scars, pigmented scars. Now, were those scars and previous uveitis due to syphilis or tuberculosis is again a million-dollar question. But looking at the scars, the pigmentary scars, very focal, multifocal lesions, I was think of a chorioretinitis. Now, typically syphilis would present with at best an outer retinitis. It would have, if at all, the lesions get pigmented. By and large, they don't get pigmented, but if they would show those fine salt, pepper and salt and pepper kind of pigmentation, rather than and they are famous for disappearing altogether. So when you treat a patient with syphilis, you may not see any evidence of retinitis per se. Okay, so unless this was a very unusual case of the choroidal involvement, I would say that probably I would think that this patient syphilis was an incidental finding. Although when we talk of the hierarchy of evidence, and when you have two tests come positive, which have nothing to do with each other, like in this patient, you have VDRL positive, which could be false positive, but TPHA is positive, which is a specific treponema test. So this TPHA being positive means patient does have syphilis infection. Okay, so whether he has neurosyphilis or not neurosyphilis, that's not the question, but he has had syphilis. And VDRL is positive. So we definitely do two tests, one specific, and the order would sometime be changed. These days, more recently, people are talking doing specific test, TPHA first, and then doing VDRL, non-specific, to monitor the response to treatment, because VDRL will become negative, after treatment, whereas the specific TPHA would remain positive forever. So in this patient. So some of these lesions even in TB, we have seen they're disappearing with use of corticosteroids. Okay, they look rosseous lesions, and you treat them with anti-TB or you treat them with corticosteroid, they disappear without a trace. So sometimes exudative reactions they do respond to whatever you might do. So there is a reason to believe that the patient responded to anti-syphilis treatment, although the retinal lesions were unusual for a syphilis. Okay, but then we know that syphilis has so much have a positive syphilis test, you would certainly treat, which you did in this patient. Okay, so the other lesion, which was a juxtapapillary, which showed very nice, that I like that ring of fire appearance on fluorescein. Very nice documentation of that, appearance of fluorescein of choroidal granulomas. Very nice. I mean, there was no doubt in my mind that it was a tubercular. You showed on OCT also the presence of choroidal granuloma. So it was a TB pathology, no doubt about it. And very rightly, the patient
Thank you so much, sir.
Yeah.
Hello. Am I audible, sir?
Yeah. Please, go ahead.
Thank you so much. And thank you to all the presenters who have made wonderful efforts to document the cases and Manisha, ma'am. I don't think she is. Okay, anyways, for all who were waiting since 5 o'clock for Sir's lecture, I would now invite Sir to present his talk, which is very interesting and which is not on uveitis, which is on something to do with teaching, and it would be a real motivation and inspiration for all of us who aspire to become a good teacher. Of course, we would never reach his level. Hello. Okay, I'll do it from my side.
So we are presenting services.
Hello. Abhiram?
Yes, sir, we are doing, sir.
Okay. If Manisha ma'am is there.
Minimize.
Cancel.
Share.
If anyone has any questions, they can write on the chat box.
Sir, is it shared?
No, not yet. Just a second. Yes. Yes, you can just play.
Yes.
Recording in progress.
Abhiram, sir's, the voice is not coming. Please check the voice. Rudvij is saying share voice from options. Abhiram? Shall I try from my side, Abhiram?
You have an option of from more if you wear, you have an option of sharing audio in Zoom settings.
And
yeah.
Thank you, Dr. Alok, for asking me to speak this evening to your residents and fellows on how to go about choosing an academic career and being a teacher in ophthalmology. Many of you might be already aware that I've spent nearly 50 years of my life in the world of academia, working in one of the best medical institutes of India. And I've had ample opportunities to watch very closely my teachers at work, my senior and junior colleagues, not only in my own department, but in other departments of the institute, as well as have watched closely my own students. I'm given to doing a lot of introspection practically on a daily basis, and it could fill a book if I wish to. So this evening, I'd like to share and summarize some of my thoughts, and hopefully my message would carry home and help some of you who are on the cusp of deciding on an academic career and going into a teaching profession will help you make up your mind. At the outset, I would like to tell you, wherever you are, academic is a mindset rather than an institute. Only academia is an environment in your department, in your institute, which promotes free expression of thoughts and generates new ideas. And you could be a teacher anywhere. You could be a teacher teaching your family members. You could be a teacher teaching your colleagues, your friends, your students, your seniors, and above all, your patients. So you don't have to be a formal teacher to indulge in teaching practices. So I'm going to take up several aspects. And first and foremost, how would you like to be? If you become a teacher, how would you like to be perceived by your students? Why choose a career in academic ophthalmology? What is expected out of you once you join this profession? And what are the challenges you are likely to come across? And as an ideal teacher, and I'm sure once you get into this profession, all of us would wish to be liked by and appreciated by your students, by your colleagues, by your seniors. So what are those attributes which will fetch you full marks? And the reality check. What is the reality check? What is the real situation? And finally, I would urge you to, as I go along the lecture, you keep checking your boxes whether you have it in you or you don't have it in you. And then it will help you crystallize your thoughts. And that's exactly why I thought I'd like to take up this subject for this evening's lecture. Bible says that God created Adam and Eve in his own image. In my own experience, I would say the students are made in image of their teacher. Over a period of time, they adopt the same mannerism, the same kind of communication skills, good or bad. They may use the same phrases and have seen my students using somewhat similar phraseology while communicating with their patients. So I think it's a very honest task. To be a teacher is not a simple job. Because unknown to you, and unknowingly your students are imbibing you, your values, your gestures, your communications, your language, your expression.
you have to be on guard all the time. So are you ready to be on your guard? There cannot be any unguarded moment. You can't let it slip, I can tell you that. You know, this is akin to the difference between shooting a movie or performing on a stage. You talk to some of these actors who perform on stage. There are no retakes. You make a mistake and the audience knows this guy has committed a mistake. They carry home that mistake. While you're shooting for movies, you know, there can be 1 retake, 2 retakes, 20 retakes, 50 retakes till you give a perfect shot. But as a teacher, there are no retakes. And in fact, same applies to the parents as well, that there are no retakes. So once you decide to be a teacher, I think you have to make up your mind. Are you going to be on alert all the time, on your guard, while you are in company of your students? Now, the 3 aspects to being in an academic environment or academic institute or as an academician. Unlike you might have seen your school teachers or college teachers, or university teachers, where teaching, and to a very, very limited extent, I would say in India, particularly the research. These are the major components. As a medical teacher in our profession, particularly medical sciences, the teachers are expected to provide a very high quality of services. So much so that you fall into the trap of a comfort zone. You're happy seeing patients morning till evening. It's a kind of a trap. It becomes be all and end all of your life. Be it in the outpatients or is in the operation theaters. Not that these are not the places. You could be an academic person anywhere, be it is the operation theater or be a teacher teaching in the clinic, teaching in the operation theater, teaching everywhere, even while you're out on a morning walk. So these are not really mutually exclusive. So you're all the working all the time. So these are but the major 3 components. And as you grow senior in the hierarchy, you might be assigned certain corporate jobs, which are by and large thankless jobs. Now, what is most interesting about being a medical teacher is that there are no formal courses. If you wish to be a teacher in a nursery school or a kindergarten school or a college or a university, you would have to go through a formal degree or diploma in education. Even for the university professors, teachers, they have summer schools where during their summer vacation, they would be taught the nuances of teaching and research at times. So there are multiple roles that are assigned to a teacher. Now I started with how would you like to be perceived by your students? Because this is very critical. You want to become a teacher, but you must know how do the students perceive you. There are essentially 3 criteria. Students, and this is not that they are thinking about it, but people say that they will be judging you, they'll be evaluating you, even all the time on your competence, on your personal potency, and whether you are supportive of the students. Personal competence, I'm sure you're all aware. I don't have to define competence, especially high skills required in surgery, the competence and skills required to solve unsolved mystery of a patient, and how you do that. But it is the personal potency, which is students perceive it very quickly, that where the teachers try to dominate. And I'm sure I have come across such teachers who used abusive language to hide their own incompetence. And they would try to control. How dare, how you walk late into my class by 10 seconds, you are marked absent. This is a sign of potency of a teacher. They would try to instill fear. I'm going to fail you. How dare you do this? How dare you ask a question? I'll see you in the exam. And I have come across in my life, and I'm sure most of you would have come across teachers who would try to dominate, intimidate you, instill fear in you. You'll be running away, from their sight. They expect deference. Why didn't you wish me good morning? They demand respect. Whereas, as a matter of fact, the respect is not demanded, it's commanded. Now, these are the signatures of a poor or a weak teacher. And I'll tell you, and I'm sure you've been victims of such teachers who would use any unjust means, maybe your internal assessment, or maybe your terminal exams, or maybe the final exams, where they would use any which way. They will try to show how strong, how powerful, and how much in control they are. In fact, it's the farthest from the truth. These are the teachers who are totally incompetent and would find no place anywhere in the world. How do the teachers, and this has been a subject of research a long time back in some of the finest universities of the world. What do the teachers, what do the students talk about? That teacher, I learned a lot going to his classes, his courses. About another one, they would say, well, I learned very little. And now the teacher himself is so confused. He's muddled all the time. He doesn't know what he's talking. The moment he enters into the class, there's a gloom in the class. There's no enthusiasm. He's finishing the lecture or teaching disinterestedly. He's not enthusiastic about what he's doing. He doesn't like teaching. It's a burden. Most of the teachers I came across, they would come and read from their written notes in the classroom. They were not interested in, actually, they didn't enjoy. And of course, students are very quick about telling whether a teacher is actually confident. Is he shivering in his pants? And I'm sure all of us have had that experience, walking into a class, and these days the classes of undergraduates could be 150, 250 students in a classroom. And if you start shivering in your pants, because you're not confident. So they'll be immediately able to tell the difference. And there are so many other, attributes in a teacher. We'll go over all these in some details, where without using any objective criteria, these are the impressions which students will carry with them to decide whether he's a good teacher or a bad teacher. Or you have to decide whether you can or you wish to be an indifferent teacher. You want to be a confident teacher, you want to be a competent teacher, you want to be fair, you want to be original when you're talking, or you just copy the notes. I have seen so many of my teachers, They cut and paste from the old textbooks or from some fancy, when all these systems came, they would copy and paste from the illustrations from the fancy atlases to show some, anatomy or some kind of physiological function or something. They're not original. The copy paste, they would, I'm aware of so many. These days, people go to attend American Academy meetings, quite a large number of people go. But in the long back, hardly anybody could afford, I couldn't afford for several decades of my career to attend those meetings, and they would give you handouts. I have seen some of the famous teachers of this country copying those notes into their slides and giving lectures, fancy lectures in some of our, national and regional and local conferences. I was shocked. I didn't know how come they're talking, And later on, I realized that those guys were using copied material without word of thanks from the day. Now, why dream career in academics? So first thing, you have to be passionate. You have to be passionate for doing research, finding answers to some of those, the questions that face you, that I must find. And you must be passionate about teaching, And many of us would like to be surrounded by students, young minds. Old folks like me, old people. There's no fun to be surrounded by old people. But certainly, you would like to be surrounded by young people who are curious. They would ask questions. They would ask very, very basic, maybe sound funny at times, but they don't hesitate to ask all those. And they provide you. I think I owe 99% of what I could achieve in my lifetime to my own students. Because there was every day, there was no let up. There is a continuous stimulus to learn. And that the majority of the learning, or most of the learning, comes by teaching. So first you have to learn yourself if you wish to teach others. And that's the way you learn. Then you get to meet people. Just imagine yourself sitting isolated in a cubicle, seeing patients day in, day out, without getting an opportunity to interact with your fellow colleagues. Here you get an opportunity to talk to them across, on a daily basis. Maybe the cornea, maybe the oculoplastic, maybe the retinal surgeon, maybe the squint, strabismologist, neuro-ophthalmologist. You get to see, even from your own specialty, maybe the uvea, maybe the retina, maybe the cornea. You get to meet each other. You get to meet each other on a practically daily basis and exchange notes. So that itself generates a creative academic environment. Okay. And compared to that, when you're in your solo practice, or even in some of those high centers where people come, see their patient, go home, they don't talk to the doctor sitting next door in the next cabin. Then when you are in a teaching institution, be the whatever level, these are essentially the tertiary care centers, and there, and I'm sure Sadhguru Netra Chikitsalaya is a referral center. So unlike sitting in a periphery in a clinic, private clinic, here you get an opportunity to see some of the most challenging patients. And if you have it in that curiosity to solve those problems, which are difficult, which are challenging, telling you from my own experience, I got very quickly bored by seeing kind of, routine patients. But if a challenging patient came and I had to work out my brain, give it an exercise. That case made my day. Seeing day in, day out, diabetic retinopathy or diabetic macular edema, not doing anything about it, giving injections, giving treatment, doing laser photocoagulation cannot hold your interest for very long. You enter into boredom, very quickly. So this environment provides you an opportunity, like you're seeing in, I'm very glad that Sadhguru Netra Chikitsalaya is now a number of publications every month, which is very exciting, because what you're helping do is from your own experience, from solution that you find from the challenges that you face in your clinic, you're extending the boundaries of knowledge. That gives you a major kick. Well, this is what I contributed. So there can't be a bigger kick than that. Getting your papers published, getting an acceptance letter itself is such a huge, exciting event. And when it gets cited by people across the world, you may not have heard of the name, you may not have heard of the country, you may not have heard of the institute or university where people cite your work. There couldn't be anything more exciting in life than that. Oh my God. They have noticed what you have said. So it can give you a kick. It can give you such a hormonal kick. You're all feeling so good about it, good about yourself, about your life, about your institute that provides you the opportunity. So this is why you would choose a career in academics. Further, you get a chance to present your work in meetings, your research work in meeting, reading a paper in front of 50 people, 100 people, 1,000 people. Some of the international meeting, there may be 2,000 people, and you're presenting your interpretation of what you found. You can share. And then, of course, most of us get excited if I get invited. Say, Alok invites me. It's a big honor for me to give a lecture or getting awards, or getting a best paper award, or getting a lifetime achievement award, or getting any kind of awards, any kind of recognition. Merely an invitation to a meeting, for podium presentation can be a huge kick, for anyone. Then, of course, there are other ancillary advantages. Most of these institutes, which are academic institutes, where you get to be teaching, they tend to have the top line equipment, the latest in microscopes and OCTs and name it. And, you would have all those which will never be able to dream of having in your own practices, or take the entire lifetime getting to spend money, a couple of crore rupees on buying spectral OCT from Heidelberg, for instance. So, but here the institute spend money on that. So you get to work on the top line instrument without investing a penny of yourself. No investment required. And, if you land a job, say like in a government institution, okay, it assures permanency. Nobody wants you are in the job in a government sector institute, in a medical college. It's well, impossible to throw you out of that job. You're settled for good. And you can probably go and tell your neighbors, and they in your own mohalla, in your own neighborhood and your city. Oh, this guy, he works in a, he's teaching in AIMS Delhi, or Vijay Chandigarh, or AIMS Bareilly, or any of those institutes. So it carries its own reward when you're recognized by the society for being in that elite group. and your name and fame spreads. When you're sitting in a clinic, in a small town or even a big town, your fame remains. You do cataract surgery day in, day out, you do excellent job of it. Your name will remain restricted in your nearby areas, in your own mohalla, in your own small city, okay, maybe in a neighboring village, neighboring townships. But when you are an academic, you have an opportunity to have your name recognized across the world. So you can very confidently say, well, in Moorfields Hospital in London, this guy knows me so well, or New York, or Miami, or Boston. These guys are so much aware of your own work. So these are some of the experiences, I'm telling you from experiences, where patients have come back and told me, look, my God, you were known in Miami. The doctor said, okay, I know that person so well. Why didn't you go to him? Now, it gives such a great moral boost to the patient, who would come and tell his neighbors, his relatives, and his friends, look, our doctors are well known abroad, even in far off countries. So what can be a bigger kick when you get recognized across the world? Of course, in your limited domain, in your own peer group, in your own field of ophthalmology or retina or uvea. But what then are the expectations? What do they expect from you? The moment you are a teacher, you are expected to generate research ideas. It's a major challenge, I can tell you. You may be asked to design a curriculum, design a course. You are no way you can find promotions or entry unless you do some kind of research which gets published. You got to know how to do literature review, how to collect data, how to interpret, how to do statistics, and how do you publish in an impact journal. So all these are expectations, even in good centers, good tertiary private centers which are doing fellowship programs, you would be expected to publish, because that helps the name of the institute, name of the center to spread far and wide. For research helps in getting you a publicity. And of course, you're expected to teach graduates, undergraduates, supervise thesis. These are time-consuming tasks. You can't say, I'm busy. You have to, once you're assigned a student, you have to guide him throughout the course of that thesis. You're expected, you are the ambassadors of your institute. So when you get up to read a paper at the podium and make a presentation, you are expected to speak confidently, because otherwise you'll let you down. So you need to learn how to communicate, how to speak in meetings. Otherwise it will be let down and it will not be tolerated by the. These are some of the expectations. What then are the challenges? Now I have told you part of the story. Now, do you have it in you? Does it clash with your personality, lifestyle, philosophy? Do you wish to have good time in life? You want to go dancing, you want to go social meeting, you want to be more interested in attending weddings, or rather than prepare your lecture for the next day. Are you ready to continuously work throughout your life? There's no let up, there's no holiday. You have to keep it up. You have absolutely no control of your time. So your family suffers, children suffer, your wife suffers, your spouse suffers, because you simply have no time for them. You can see some of your own teachers, they may be spending 12 to 14 to 16 hours a day in the institute. And there's no compensation proportional to the time you spend in the in the institute. There's no pay package. And I'm sure Chitrakoot is known for being a saintly place. So perhaps many of you stay for reasons other than, quickly learning the skills, surgical skills and other skills in this institute, because you are forced to live. There's no social life per se in a place like that. So it's very, very difficult to retain teachers in an institute like Chitra. Hats off to those of you who are continuing to stay, shows your level of commitment. And teaching students these days, a class full of 150, 250, and you are not up to it. They're sitting with their smartphone, their iPads. They can tell you, okay, doctor, you're wrong. Sir, this is what the latest research says. They're quick with their smartphones. Within a matter of seconds, they will find out if you're wrong. So you have to be all the time. And as I said earlier, also coming up with original research ideas can be a major, major challenge. Now, I will go over some of these attributes which are ideally present in a teacher, and you got to check the boxes whether you have it in you or not. It will help you crystallize ideas. Are you a passionate person? Do you take it as a burden? Daily, you come to the hospital, see patients, face challenging patient. Do you find it's a burden? I'm tired, I'm exhausted. I had a very tiring day. If you're like that kind of person, then teaching is not your place. Academic world is not for you. Commitment. I have come across so many teachers, maybe more than 50% of the teachers in my own institute, unhappy all the time. They lack commitment. They're neither here nor there. They're all the time looking at their pay scales, their dearness allowance, their expenses. They're missing out on life, They're unhappy. But mind you, in academic environment, either you have it or you don't have it. There are no half measures. Okay. So either you take it or you don't take it. It's as simple as that. And as I said earlier also, there's no package which will compensate for your time, for your passion, for your commitment. There's no way you will be. It's absolutely a free, this is only for your own satisfaction that you do it. This is what we call altruism. It's altruistic. There's no compensation proportional to your inputs. Because being an academician is a reward in itself. It's the biggest reward if you enter into that. And of course, I told you peer group recognition. Now, I have very often heard some of the busy, surgeons, especially the refractive surgeons, cataract surgeons, who day in, day out are minting money by operating. You guys are lazy. They often taunt us by telling us that we're lazy. I can tell you it's far from the truth. To be able to survive honorably, be able to teach and do research, not only you need to master the subject, but I can tell you that, and from my own experience, I have to be 10 steps ahead of my students, even at this advanced stage of my life. When all my faculties are slowing down, I have to work 10 times harder than the students. Why do we exist? Many of us exist because of the lazy students, not because of that we are lazy. No, It's the students who are dishonest. Otherwise, they can catch us anytime, any point of time. This comprehension, I think this is one attribute. You can test it for yourself. When presented with a problem, are you able to comprehend quickly? And many of my colleagues, they had to be told 10 times, it had to be repeated. They won't comprehend. They would not appreciate what the patient is trying to tell him. What the problem is being presented is, what's it all about? What the paper is all about. They're not able to comprehend the contents of the paper, yet they happen to be in academic world. So comprehension, you have to test for yourself. You've got to be fair to all your students. You can't be unfair. You can't be showing favoritism, you know. And teachers are essentially leaders. They have to play the role of a leader of a group of students who are with you, whether you're fellows, whether you're residents, or whether you're undergraduates. And that makes the job very risky. You don't want to be seen, lose your face in a class full of inquisitives. You have to be on top of them. So sometimes it's so much easier, rather than do any original research, have any innovative ideas or research ideas. And I used to, at least in my undergraduate career, I found most of my teachers were hardly ever publishing a paper. They were very happy. They would be underlining each line written in a journal. I found a lot of people in India are fond of writing letters to the editor, criticizing a published paper for no good reason. And I've yet to see a letter to the editor criticizing paper, which was genuine criticism. So easier to criticize rather than evolve your own research ideas. Now, as a teacher, specifically when you are expected to generate research ideas or a lot of thesis subject to the students, you have to think ahead of others. Think ahead of others. At some point of time, think ahead of your competition across the world, not only in your own institute or in your area, in your region, in the state, in the country, but across the world. You have to keep thinking, how can I beat others in the rest of the world? And this is one weak area, I would say, in India that I have come across, that there are very few original ideas that get generated. Most of them are copycat ideas from somewhere research done in Europe or in US, and you copy it. I have seen people, for anything that goes wrong, blaming the student and not taking on the onus. If your thesis paper doesn't get published, you blame the student. You didn't do good work. You didn't write it so well. No, I think that speaks of very poor teachers who find blame with the students. And I think you have to take your team along. You have to be able to guide them. You have to become a friend to your team. Okay. And one of the finest examples in India has been of our former president, Abdul Kalam. He was not a great scientist. He didn't have any engineering. He didn't have any high-fi degrees or PhDs from any universities. But yet, he was one of the most remarkable scientists that India produced, just because of his ability to be a great team leader. He could get the best people, best minds to work together on a problem till it got solved. So you don't have to be Einstein all the time. As a teacher, it's your job to get people to work together. And above all, as a teacher, because you are the ones who have spent years in the profession. You have faced those challenges in the past and you have become wiser from those good or bad experiences. So you have to, it's your bounden duty to teach the students how to apply correct knowledge. Application of knowledge is what is wisdom. It's your duty to make the students wise. So you have to teach them how to apply knowledge, contextuals, and make them gain that experience much quickly. And you have also got to teach. All the time, the focus in our classrooms has been asking questions from the students. Whereas I feel it should be the other way around. It should have been the teachers who need to inculcate this habit, encourage people, encourage students, fellows, residents to keep asking questions. Whether you have the answers or you don't have the answers doesn't matter. Good teacher would be able to say, I don't know. I don't know. You should be able to say immediately as a good teacher, I don't know. Let's find out. Very often the Indian context, I'm telling, there has been research, they do their PhDs, they do their MDs, thesis, and they say research by the students, whereas it has to be researched with the students. You also participate to help the student. I mean, I've had teachers who would say, go and find out the answer to this question. No, they should have told, look up this book. I'll do the physical labor of going up to the library. I'll do the searching, but at least give me an idea where to find this. Give me an idea, but we did have teachers who would give us the exact reference. Okay, look up this reference. I'm not able to, I don't have it with me, but please, can you go and find out this reference? It might provide us the answer that we're seeking. And, ability to generate simple questions. Like one of the papers we published almost 30 years ago, it was very simple. We were doing day in, day out focal laser photocoagulation of diabetic macular edema. We were targeting the leaking microorganisms as a gold standard. It used to be of clinically significant macular edema and diabetics. Nobody till that time had asked very simple questions. That after you do a focal photocoagulation, when do the microorganisms close? I don't think, I'm just giving you intentionally an example which could be simpler than this. It's amazing. Nobody had asked a simple question at that time. And there are numbers galore. I can give you any number of examples from my own experience. And what did we find? We found that none closed at 48 hours. By 3 months, 75% of microorganisms were closed. Nobody has said that. Till date, nobody knows what is the mechanism of closure of these microorganisms. It's not as simple as people will say, there is a thermal coagulation. If it was a thermal coagulation, the microorganism would close by 48 hours. It's not that simple. It's not that simple, I tell you. This remains, even till date, it remains an open question. How do, after any particular therapy that we do, how do the microorganisms close? How do they disappear? There is a difference. And very often when I ask my students, how many patients you saw today? I have seen 100 patients. Okay. And I would ask, can you recall any patient? No, sir, they were all like that, the routine. So what they have done actually is they have navigated through the day. They reached from point A in the morning to point B in the evening. In the course, they came across 100 patients. And when we say seeing, is perceiving something in the brain. What you perceive through the use of your eyes, through the use of your retina, you perceive. Seeing is not something which registers in the brain unless you're curious at that point of time. Why does the patient have this problem? Why does he have critic precipitates? Why does he have this patch of retinitis? So unless any unusual feature in the patient arouses your curiosity, it will not make an impression on you. When it makes that impression, we call it observe. We call it observation. And for making those observations in an academic environment, you need to use, valid tools like an image, like an OCT, or like an angiogram, or an ICT, or so valid tools, or an OCT, or some such thing. Observations are the keystone of science. All sciences, pure sciences, the earth sciences, the medical sciences. And we as ophthalmologists would realize we are the best of all, because it's all about observing. We can see it all, and it's up to us individually whether we do observe, we do have keen sight, we do have insight. Okay, these are some of those. Once you have an observation, you make an objective observation, you need to develop insight into what might be happening. You need to be able to see through the pathology of that, pathogenesis of that, and how you can best deal with that. Once you know that, you would immediately come to know, okay, my God, the answer to this particular problem is not known to anybody. So you reach the outer boundary of not the universe, but you reach the outer boundary of knowledge, which is as akin to the outer boundary of universe. When we know that it's expanding, so is the knowledge expanding? Reaching the outer boundary of the universe or reaching the outer boundary of knowledge is a challenge. And that will come from when you teachers arouse the curiosity of your students to generate those questions which will take you like on a rocket, reach that outer boundary. As a teacher, are you an effective speaker? Are you able to communicate very effectively? Is your expression clear? Do you keep your talk interesting? Do you tell short stories, anecdotes for minutes? Do you keep the students interested in your talk or what you're trying to teach? Do you speak slow? Let that information sink in, and because that is very important. But what I have seen, speakers, teachers, they start rattling off, going through slides, going through their presentation, going through their lectures, as if they have to catch a flight and they're getting late for that. They show impatience going through that. And when a teacher is going through like that, it shows that he's incompetent. He's hiding his own weakness. When he's not slow, when he's not deliberate, when he's not letting the facts sink in, he's afraid. He's moving on at breakneck speed. The students may not check him, may not ask a question, and he'll be found wanting. So they don't allow that to happen. I'm not suggesting that non-academic physicians or clinicians are dishonest. But here, being a hugely competitive world, the academic people tend to be at times dishonest. They're trying to, they may be tempted to fake data. They have seen 10 patients. They may say, I saw 100 patients. They may report data which is fabricated or which is plagiarized. Anything like that you do, and make a false claim, fate is going to catch up one of these days. I can assure you that. I can tell you that. People have been caught. Big time people, big time near Nobel laureates have been caught lying through the teeth, manipulating their data, fabricating. So don't do that. Now we are living in a world, we are getting bombarded by information. Not only, I'm not talking the social media, but we're getting bombarded by information from millions of papers that get published everywhere, even in our own field. There are lakhs and lakhs of papers, often with contradictory observations, often with, methods that are less than, I would say, rigid or stringent. The statistics which has been applied to suit the writer and not the science. And the teacher's job is to be able to crystallize those ideas, synthesize those ideas, to bring about the differences, the conflicts, the weakness or strength of that data or information. And these days, people would like to put it as a kind of a systematic analysis or a meta-analysis of all that published information, because published word is not the gospel truth. It suffers from several infirmities. And the job of a teacher is to crystallize from all that this information may be good, it may not be valid, it may be untrue, it may be patently false. So that is the ability. You need to have a positive attitude. You can't be keeping company of cynics. It will never happen. You'll never be able to do this surgery. You are such a foolish person. You'll never be able to do research. You are not good. No. You must have that never say die. I'll attempt. I will do my. I'll not run away from a surgery. So you need to have that all the time. A positive attitude. And this is very, very important while doing surgical procedures, which are hugely complex procedures. As a teacher, you have to be restless. You can't remain in your comfort zone. You have to say, well, you have to cross the boundary. You have to take up, accept challenges. You have to be in the quest for bigger, better, higher. Always keep moving. Keep the bar moving. Keep changing your objectives. Keep changing your goalpost. Let it keep moving. That is how you'll be able to. You can't say, well, I'll publish 5 papers or 10 papers in my lifetime. That's good enough. No. People who are restless, who are seeking much higher, their hunger for more and more keeps growing as you grow more. Now, this is something very interesting, and I can tell you. I don't know from where did I get it. I think I saw some of my teachers who would attend a conference. Most of them would go abroad to attend a conference. They will acquire a piece of information. They will have some knowledge. They will not tell what did they know. They will not come and tell, never share. They read something they will never share with you. Because what will be the difference between him and you as a student if he doesn't share that information? Now, one way of learning forever is sharing. So all my life, I can assure you that whatever I read, and I read practically every day, something new. I would next morning, I'll share it with my residents, with my colleagues during the coffee break or tea break. I would say, well, I read this information. Now it reinforces that information in my mind. Others get an idea. They can't steal your ideas. They don't get better by or they can't move ahead of you. But something unique about knowledge. If you know something, it'll die with you if you have not shared with your students or with your colleagues. The more you share, the more it grows. Unshared, you will yourself forget very quickly, I can tell you that. You learn to share. You have walked the talk. You have to create an enabling environment where students feel free. They don't feel scared of you. They feel free to ask you anything, to express their apprehensions, reservations. Don't dismiss. What do you know about it? No. Nobody is perfect in this world. They can certainly give you wise counsel. They can certainly give you a good research question. They can always tell you, sir, I read this, can we do this way? So you need to create that enabling environment. Okay. And as I said, you must practice what you preach. You can't be coming late to the class or to the hospital and punish your students for coming late. You can't be dishonest and expect your students to be honest. You yourself are lazy born and you expect students to work hard or ethical. You do unethical procedures. You shout at the patients and you don't like if your students shout at the patients. So when I said that you are like a performer on the stage, there's no let up. Not for a moment, because if your students start doing the same and you don't like it, then you have to have very high standards of ethical behavior. I was let down by some of my teachers, when I realized that they were not being totally honest. And one of them had the calls to tell me, okay, you take it, take it with you, this piece of instrument, because you will need it in your practice. Of course, I never went into practice. And I said, how come? I had kept him in such a high esteem. I had kept him such a high pedestal. He fell down in my eyes, in my esteem. I said, he's telling me to steal from the hospital. What kind of person is he? So never do these things. You have to walk the talk, all the principles. And all your life, there's no let up. Now, finally, I'm coming towards the end of my talk, and I'm sure by now you would have seen what are your strengths, what are your weaknesses. Nobody can be perfect. And the academic environment is hugely competitive, full of, at least the initial years are full of uncertainties. There's no assured career path. You may not get your promotions. There are fewer job opportunities. More people, the top tier, not retiring, not leaving.
I think sir can take over from here, sir.
I think I think they're kind of a longish lecture, but I want you have to be able to accept criticism in open forums. I've been called names when I was introducing infectious uveitis in India. I was literally abused, given MCBCs in a hall full of people, by those guys who were living in the past century. I would say that. Okay, so sometimes when you come up with new ideas, when you submit your paper, it gets rejected. The critical comments that you get from the reviewers, okay, your paper, despite all the labor you put in, it gets rejected. It can be very, very depressing. So over a period of time, you develop a thick skin. You take things, in the spirit in which they've been. You become a better person. With each criticism, you get to become a better teacher, a better researcher. So I think that's what I would like to say towards the end, and give an opportunity now to, if you have any experiences to share, or some of the students might have some questions raising in their minds, most welcome to raise any of those questions.
Even from
with the Western world, we might claim we are one of the fastest moving economy, but in terms of student-teacher relationship, I think we are one of the most backward nations. If I can say, our students are still scared of teachers. They're not able to openly, freely express themselves, their apprehensions, their reservations, or their expressions of their questions, but that, teachers are going to mind. No teacher would mind. Let's have an open environment, where a friendly environment will grow together much faster, much ahead. We are no less than the rest of the world. But this is where I find the major block is the student-teacher relationship is the poorest in our country compared to the rest of the world, where they move faster, much faster, because they work as a team, and both teachers and students work together.
Sir, you are such a wonderful teacher and you motivated me since almost now 30 years. I first heard you at RP Center when you and Professor Tiwari used to speak on diabetic retinopathy. And as a student, I would say, I was motivated because of your talks, and I started doing work on diabetic retinopathy. And that time I was knowing nothing about diabetic retinopathy. It's all your motivation and the way of teaching and the skill that you have put in all.
To you for even
I
always
say that, sir, Alok is a boon for us.
Yeah.
Because he is so nearby, and we keep on referring all our cases to him. And I've been watching team coming to
So they were the teachers at that time, and they taught me actually uveitis, and I started developing interest in uveitis. So I have learned more from my students than probably I could have taught them in my early days. And then I realized that how much more important to have good students around, because they are real, as you rightly pointed out, they are the stimulus for you to read more, get more knowledge, and then you can actually reply them or crystallize the information for them. So Pawan is here, and I owe a lot of my uveitis knowledge to him, because he used to say, always tell me, sir would draw sketches on paper and make us understand what is going wrong in the eye. And then he would always tell all the anecdotes that you had shared with them. So that was a great learning experience for me. Thank you, Pawan, and thank you, Mohit, and others who have been always stimulating us to do well. Thank you, sir.
So absolutely.
Yes. Pawan, I think Dr. Rutendu has raised. So can someone unmute? Sir, you can speak now.
Good evening, sir.
Good evening. How are you
Yes.
doing?
Sir, it's a privilege listening to you after so many years. And sir, actually, perhaps you are the reason why many of we residents stayed in ophthalmology. Currently, I have joined as an assistant professor in AIMS Bhubaneswar. Sir, yesterday, one of my students asked me, am I doing the right thing in staying MS ophthalmology? He has just joined 1 month back. So he is in a great deal of confusion because people are saying कि ophthalmology में क्या रखा है, तुझे medicine ले लेना चाहिए था. So he was really confused. Like कि मैं ophthalmology लेके ठीक तो कर रहा हूँ ना. Sir, how should I correctly guide him?
Yeah, I think it's a question which needs a full lecture. How do you, kind of weigh in which discipline to choose? And this is a debate which goes on all the time, even in the most advanced countries like the US, when they have to choose which subject to follow, which subspecialty to follow. So there could be several motives, whether it's unexplored, discipline, or it fetches you a lot of money, or it's exciting. So some people, or it's a high risk taking, like in neonatology or obstetrics, or you want to feel great doing a cardiac surgery, you want to do a cardiac transplant. So people have different ideas, and I don't think any discipline, be it dermatology, be it anesthesiology, or all of them are doing great things in their own field. Okay, you could have a different motivation, to be a psychiatrist, or most of the times as students, undergraduate students, we get influenced by the kind of teachers that we see, the kind of role models we develop, or we see them and we want to do something like that. So I think that is what is the guiding principle. Who impresses you the most? And I think I have deliberated length. What are those criteria as the undergraduate teacher which you should try to adopt? And not all, it's not possible, but most within your reach. Only thing you have to be conscious that you're a teacher. And I have seen people, even in my own institute, smoking openly. The professor of medicine smoking in his cabin, while watching patient, while dealing with the patients. They didn't realize how much they were impacting the undergraduates, by their behavior, which nobody would condone it in the present day. So when I have seen very senior surgeons, abusing patients, hitting patients, throwing instruments on the floor, abusing the nurses. Now, those are the kind of things when you see your teachers doing, you develop distaste for that kind of role models that they present.
Yes, sir. I still remember the welcoming lecture which you gave when our batch joined. That I assure that this is one of the best decisions of your life, joining the ophthalmology.
Yes.
What you said in 2008-9 when we joined this. I was confused because I was pursuing MD pediatrics, and then shifting to ophthalmology was a big decision. And those your welcoming lines of those times, it seemed that as it were meant for me only. I was just astonished. How can I thought it's a as Alexa said, it's a God's voice, and that was one of the best decisions in your life. And the secondly, when you said me to go to Chitrakoot, that was the second best decision of my life. Learning from Alok sir, and you were he used to come in the 6 a.m. in the morning to assess the cities with me.
Yeah, that's right.
Me and Alok sir used to sit and look into the OCTs, and the hard work which he has and still he has is and
it's showing up.
You always used to say that the thing which we miss in our country is that we're never taught to how to generate the questions since our childhood. That's the problem we have. And thank you so much, Alok sir and Amod sir, for everything we have.
Thank you.
Thank you very much, sir, for the guidance.
I think we all have learned so much from sir, and whatever little I know of uveitis or research or publication, I still remember the first paper which got rejected, a case report, and I had sent across to Amod sir, and he was so critical that why it got rejected, and we were wondering why, and then he point to point he sent me an email, and I still have that, and it keeps reminding me how you should actually prepare your publication material. So thank you so much, sir. I think I cannot in any way I cannot उपकार नहीं ये कर सकता. It has been a learning journey for me, and I think it has been a learning journey for everyone who have been close to you over last few decades or so. Thank you so much. If anyone else has anything to say or comment, otherwise we have already taken a lot of time from sir, 2.5 hours. It's 7:30. We can. I think everyone enjoys his company. We can talk through the night.
These are endless discussions, These are endless.
Yeah, and still we will be awake and alert. So at the end, I would like to thank each and everyone who has made an effort to make the presentations. Dr. Anu, Dr. Gaurav, Dr. Pranav, and Dr. Tanvi. They had really worked very hard to come up with beautiful, well-documented cases. And I'm sure everyone else who have attended must have enjoyed the presentations. And as sir has rightly pointed out, we'll try to make some of them as publications very soon, or all of them as publications very soon.
Yeah, absolutely.
Yeah. And I also thank all those who have joined in, who have taken finished their work early so that they can come and join and enjoy this webinar and sir's talk. I also thank the IT department from Sadhguru Netra Chikitsalaya to have make all the arrangements for this webinar. And last, I cannot thank more Professor Amod Gupta, because whenever I think of any webinar, he is the first name that comes in my mind. And sir, thank you so much for everything that you have done, and you have motivated, inspired, helped, supported in our ups and downs. And I hope we continue doing good work at Chitrakoot and make you proud one day.
Thank you. Thank you. Thank you, Alok and Kamalveer Singh, for being there all the time. I have definitely, it's my passion. You might have seen, I enjoy your company. I enjoy the company of students. and you extend my life when you ask me to participate in your meetings. You give me a lease of life. So to that extent, I'm grateful to you and Sadhguru Chikitsalaya and Dr. Jan who set up such a beautiful institute, and I wish you all the best in life. Thank you, and thank you, Dr. Kamalji Singh, for being with me. Yeah, thank you.
Thank you all, and we call it a day for today. Thank you, sir, and hope to see you soon in person.
Yeah, thank you. Thank you, everyone. Thank you.
Bye. Good night.